All right. Well, thanks so much, everyone, for coming this evening. Tonight, we'll be discussing the comparative oncology of melanocytic neoplasms in veterinary and human patients. I'd like to thank both of our speakers, Dr. Jedd Wolchok and Dr. Rachel Lordahl, for joining us tonight. Jedd Wolchok is the Meyer Director of the Sandra and Edward Meyer Cancer Center at Weill Cornell Medicine and Professor of Medicine at Weill Cornell College. Dr. Wolchok is a clinician scientist exploring innovative immunotherapeutic strategies and laboratory models, and a principal investigator in numerous pivotal clinical studies. Dr. Wolchok has helped establish immunotherapy as a standard approach to cancer treatment and was instrumental in the clinical development leading to the approval of ipilimumab and combination of nivolumab and ipilimumab for advanced melanoma. He supervises an NIH R01 funded basic science laboratory, which is focused on investigating novel immunotherapeutic agents in preclinical laboratory models. The focus of his translational research laboratory is to investigate innovative means to modulate the immune response to cancer, as well as to better understand the mechanistic basis for sensitivity and resistance to currently available immunotherapies. Dr. Wolchok received his BA degree from Princeton and his MS, PhD, and MD degrees from New York University, and has received numerous honors for his work, including the American Association for Cancer Research, Richard and Hinda Rosenthal Memorial Award, the Giants of Cancer Care and Melanoma Award, the Burson Alumni Achievement Award in Clinical and Translational Science, and we're very happy to have him here with us this evening. Dr. Rachel Lordahl received her doctorate in veterinary medicine from the Atlantic Veterinary College in 2019, and this was followed by an internship in medicine and surgery, as well as a specialty internship in medical and radiation oncology at the Veterinary Medical Center of Long Island. In 2021, Dr. Lordahl joined the Schwarzman Animal Medical Center, where she completed a specialty internship in oncology, and she's now currently a resident in medical oncology. So thank you both to Dr. Wolchok and Dr. Lordahl, and we look forward to hearing your talks tonight. And so with that, I'll pass over the mic to Dr. Lordahl to get us started for the evening.
Thank you, Dr. Ferrari, and thank you, Dr. Wolchok. It's an honor to join this talk with you. I'd like to introduce melanoma first as a challenging tumor. This tumor has a broad spectrum of malignancy. It can be poorly compliant with predicted patterns of behavior, and no single treatment option is consistently best, although we know that there are various different treatment modalities, all with potential application. It is a very common tumor in dogs. Most tumors are located within the oral cavity of dogs, and additional sites include cutaneous, digital, and subungual, or beneath the nail bed locations. Ocular melanomas have two distinct phenotypes, both malignant and benign, with varying anatomic sites implicated. Different breeds are predisposed to different anatomic sites. For example, a Scotty may be predisposed to the oral form, whereas a Schnauzer might develop a subungual lesion. It's unknown if prognoses with melanoma differ according to breed, and given the significance of genotype in human melanoma subtypes, this may be an interesting area of future study. On the other hand, melanocytic neoplasms are quite rare in cats. If we see them, they may be located on the eye, hair, skin, or in the oral cavity. Continuing my talk, I'd like to clarify some terms. When we speak of these tumors, they're collectively referred to as melanocytic tumors, which are tumors derived from melanocytes, regardless of whether they are benign or malignant. Melanoma and malignant melanoma are malignant tumors, again, derived from melanocytes. And then on the other hand, when we speak of melanocytomas, we're referring to benign tumors. Please note that these terms are not concrete, and different pathologists may use them interchangeably. Clinical signs are referable to the affected anatomic site. When we see patients with oral melanoma, they may present with oral bleeding, weight loss, tylism, dysphagia, and you may notice a large mass present in their oral cavity, as depicted in the images here. Melanocytic tumors of haired skin are phenotypically benign, and they may appear as raised, pigmented, mass-like, non-inflammatory lesions. They may also resemble small, flat, black to tan masses, and they can be present for a long time. And if you recall in yesterday's evening's talk, Dr. Pavlik did mention that these skin tumors in humans, although non-melanoma, can also be present for a long time. And that's why it's important to be aware and notice these things when they occur and present them to your family doctor for evaluation. Certain sites of malignant melanoma on the skin, such as the digit, foot pad, and scrotum, are associated with malignancy. These tumors are especially fast growing. They can be ugly, ulcerated, and pigmented. The image at the top of the screen shows a foot pad melanoma in a dog. Subungual or under the nail melanomas are awfully painful. They may appear as a non-healing lesion near the claw, and patients can present lame, they're painful, and they may be excessively licking the site. Ocular melanomas, they can present in a variety of ways, and it really depends on the clinical sign that is as a result of the lesion. So for example, in the center image, you'll see a cat presenting with unilateral glaucoma secondary to melanoma. The middle photo depicts iris pigmentation in a cat. And then in our canine friend down below, you'll see that there's an eyelid tumor, which was confirmed to be melanoma. A quick note on comparative aspects of human and canine melanoma. The common sites of malignancy differ. In canine, this is typically oral and subungual, whereas in humans, it could be ocular and cutaneous truncal. Generally, human melanoma is associated with UV light, whereas canine is not typically associated with UV light and has a low frequency BRAF mutation. We know that BRAF mutation is implicated in human melanoma. Canine melanoma also has abnormal suppressor expression at P16, P10, P53, and P21. Gain of chromosomes have been noted at 12, 17, and lost at 22 in canine malignant melanoma. Now we'll speak on cytology, and you'll learn that there's various different ways to obtain a diagnosis of melanoma. The first is cytology, and I'd like to mention that melanoma subtypes exhibit great variation in their cytomorphology. And for this reason, we'll need to use a combination of diagnostics to get our answer, which I'll go through in the coming slides. On cytology, we may see that melanoma is variable in cellular morphology. As I mentioned, it can be a round cell, epithelioid, or spindle-shaped. Many melanocytic tumors are heavily pigmented, and this makes the diagnosis relatively straightforward. In some cases, the pigment is described as fine, dust-like, needle-shaped, granular, or coarse within the cytoplasm. But infrequently, melanomas can be devoid of melanin pigmentation, and this renders cytologic diagnosis challenging or impossible. So in order to point out what I am referring to regarding the challenge of cytology, I wanted to display normal appearing melanophages compared with metastatic melanocytes. The melanin-containing cells on the right of the screen are consistent with melanophages. Melanophages are macrophages which take up dermal melanin and traffic it to the lymph node for processing. In speaking with our clinical pathologist on site, she notes that the distinction from neoplastic melanocytes is the appearance of the pigment, which is described as chunky rather than fine. Note the image on the left that represents metastatic melanocytic neoplasia. Many of these cells are lacking pigment and have significant atypia. As a result of these subtle changes, histopathology with or without histochemical and or immunohistochemical staining is required to obtain a diagnosis. Another key feature on histopathology is junctional activity. This refers to proliferation of neoplastic cells at dermoepidermal junctions, and this can really aid in diagnosis. And the reason why I'm mentioning this is because when you are biopsying these sites and you're suspicious of melanoma, care should be taken to preserve the part of the epithelium to improve your diagnostic yield, as you may note junctional activity in this portion of epithelium. If we need more clues, we can rely on histochemical and immunohistochemical staining. We have a couple of options to rely on here. The first being the Fontana-Mason black stain, as well as the Schmorl's blue to green, which can be used to highlight melanin. Prussian blue stain aids in differentiation of melanin granules from hemosiderin by identifying the presence of iron. In addition, pathologists use bleaching, which helps visualize intracellular structures by removing the melanin from tissues. At AMC, we are often ordering these panels in addition to our histopathology read, and we're lucky to have access to an immunodiagnostic cocktail which comprises of melanin A, melanoma-associated antigen, and tyrosinase reactive proteins 1 and 2. And this cocktail has a 100% specificity and about a 93% sensitivity for identification of canine oral amelanonic melanoma. So when you have these challenging cases, you will need to rely on additional measures of diagnostics, such as immunohistochemistry. And it's a very simple thing to add on in communicating with your pathologist. You would suggest adding on these tests, and they would partner with you to help you decide which is best. Proliferation indices and biomarkers. We do know that the proliferation marker Ki67 is useful in distinguishing benign and malignant forms, and it has prognostic value. A higher percentage of cells express c-Kit and melanocytomas than in malignant types, but c-Kit expression did not correlate with prognosis in malignant melanomas. An additional parameter called high microRNA 126, which is an increase in small regulatory RNA, has been prognostic in canine melanoma and associated with a shorter survival time. Additionally, a decrease in chemokine, which is called CXCL12, as well as an increase in DNA binding enzyme, are associated with metastasis. Clinical staging. So we'll go through the WHO criteria, and the clinical staging of melanoma is relatively straightforward. The goal is to determine the clinical stage according to the World Health Organization and to provide prognostic criteria to guide therapeutic decision-making. A validated clinical stage scheme has been defined for canine oral melanoma. For all other locations that I spoke about previously and for feline melanoma, a TNM-based staging applies. The primary tumor size is of prognostic significance, and it can be clinically measured with a caliper if you have, or by cross-sectional imaging with CT scan. In measuring, the longest diameter should be used for the classification. Something else to note is that depth and nature of tissue invasion may be presumed to be prognostically significant, especially some of these really invasive large tumors that we see. We can't assume that that would supersede tumor size. In fact, the nature of tissue invasion and depth are not included in the recognized clinical staging scheme. When lymph node status is uncertain, histopathology is the gold standard for assessment of lymph nodes. I'd like to point out that lymph node size alone is an unreliable predictor of metastasis, and oftentimes in the clinic, we palpate normal sized lymph nodes, and in fact, the patient does have a metastatic node. A 2023 study of 100 dogs with oral malignant melanoma identified 53% of cases with cytologic or histopathologic evidence of mandibular lymph node metastasis, and that includes those of normal lymph node size. So please don't rely only on palpation. Advanced staging techniques such as selective biopsy of the sentinel lymph nodes or bilateral excisional biopsy of local regional lymph nodes can be considered. In the images shown here, I've displayed sentinel lymph node mapping, and you'll see that the red circle represents the primary tumor, and the red arrows represent the sentinel lymph node. In detecting metastasis, we can use 3-view thoracic radiographs or CT scan. CT scan is more sensitive for detection of small pulmonary nodules, and in canine cancer in general, only 9% of pulmonary nodules that can be detected by CT are visible on radiographs. Another way to look at that would be patients that have thoracic radiographs without pulmonary nodules, up to 39% show nodules on CT scan. Distant metastases also include the abdomen. It's rare, but it has been described in the abdominal lymph nodes, the liver, adrenal glands, and even skeletal metastasis. We'll move ahead to local therapy. Local therapy with surgery. Surgery is one of the best initial treatments, and the recommendation is a definitive surgery. The technique depends on the location of the primary tumor. For example, a foot pad melanoma may require a partial or complete full thickness resection. And a technique that is used by surgeons for this location is something called a phalangeal fillet technique, which I displayed at the top with the 3 photos. Other surgical techniques for ocular melanomas are listed here, and it depends on how aggressive the tumor is. So, for example, a conjunctival melanoma in a cat is very aggressive, and therefore an orbital extenuation will likely be recommended. Radiation therapy is also an integral part of melanoma treatment, both as a primary and an adjuvant therapy. Melanoma is sensitive to coarse fractionation. An optimal protocol is unknown, and the reason for this is that most published studies are retrospective, and the variety of fractionation varies, the equipment can vary, simultaneous treatments will vary, and clinical stage is hard to standardize amongst these patients. So we ended up here at a very pivotal point where I was starting to introduce Oncept, which is one of the best treatment options that we have available for canine melanoma. And like to give credit and recognition to Dr. Wolchok, who was pivotal in developing this therapy for our patients. In a prospective multi-center clinical trial, we found that dogs treated with Oncept in stage 2 and 3 oral melanoma had a survival benefit in those treated versus those treated with surgery only. Oncept is a therapeutic vaccine containing xenogenic plasmid DNA with an insert encoding human tyrosinase. And tyrosinase is a protein that's expressed on the surface of normal cutaneous melanocytes and is overexpressed on malignant cells. The purpose of this therapy is to trick the immune system in identifying this, which will then target an immune-specific response. So the image here, you'll see a delivery of the vaccine. Upon injection into the dog, the plasmid DNA is taken up by the host cells. The human tyrosinase protein is then produced in the host and actively presented to the immune system. We've also looked at use of Oncept for digital melanoma and identified significant prognostic factors, including the presence or lack of metastasis at the time of diagnosis and the stage of disease. We know that Oncept can safely be administered to cats as well as horses and rabbits, but we don't have any efficacy data, although anecdotally we do see response. There is no evidence that the addition of cytotoxic drugs leads to improvement when looked at surgical treatment. Other modalities of treatment that I'll just briefly go through include COX inhibition, intralesional cisplatin implants, electrochemotherapy with intralesional bleomycin. And then metronomic chemotherapy, it may influence the immune cells of the microenvironment, but the significance remains unknown. Tyrosine kinase inhibitors, we've previously looked at masitinib, which has mild effect in stage 3 and 4 malignant melanoma. And then I'll wrap up my portion of the talk with introducing checkpoint inhibitors, which are successfully used in human melanoma. And as we were introduced to last night, gilvetmab, which is the first canonized anti-PD-1 monoclonal antibody. In a study of 25 dogs with stage 2 and 3 melanoma, we saw 2 of 25 had a complete response, 3 of 25 having a partial and stable disease, and 10 of 25. And then I'd like to end off with our future direction for this tumor type in veterinary medicine. It would combine genomics, tumor mutation analysis, tumor expression profile, and targeted therapies. We're also really excited to learn more about combination therapies and the ideal timing of such. And I look forward now to learning more about the use of checkpoint inhibitors in human melanoma. Thank everybody for their patience and bearing with me with this slide error, and thank you for your time.
Well, thank you, Dr. Lordahl. I'm gonna try and share my screen. Okay. How's that?
Great, I can see it perfectly.
Okay, great. Well, thank you, of course, to the organizers for the invitation to present at this conference. And thank you to Dr. Lordahl for the really complete and outstanding introduction to melanocytic tumors. I appreciate the shout out there too. Thank you so much. And I think it'll make this part of the presentation much easier for me to do. So this is just some disclosure information for this audience. I should, as was just said, disclose that I receive royalties for the Marielle vaccine, and the rest is more related to human health or drugs in development. So one very important part of consideration for the treatment of advanced melanoma in humans is really understanding the basis for immunotherapy. And to understand the basis for immunotherapy as a tool to control cancer, we need to ask ourselves these really two basic questions. Is there an immune response to cancer, and can the immune system reject cancer? And now in 2024, we know conclusively that the answer to both of these questions is yes. And I'm going to go on to tell you how immunotherapy has been such a critical tool in our ability to change the prognosis in human metastatic melanoma. But really, we need to better dig into understanding whether cancer looks to the immune system like the normal cell that it came from, or does it look like a foreign infectious pathogen? Because we know that the immune system, whether it's in dogs, cats, or humans, is very adept at recognizing pathogens, bacteria or viruses, but we're until recently a bit uncertain as to whether the immune system can recognize cancer. And I think that in sort of the self, non-self paradigm, cancer is probably best categorized as altered self. That it doesn't exactly resemble the normal cell that it came from due to the production of altered proteins because of genetic mutations, some of which lead to the cancer. But it doesn't really fully look like a bacteria or virus. It's really somewhere in between. And what we've learned, at least in human cancer, is that the degree of genetic damage that a cancer presents to the immune system is really a reflection of the number of what are called neoantigens, the number of abnormal proteins that look unlike self, and the degree of genetic damage, sometimes called the tumor mutation burden, is actually a good indicator for the likelihood of that particular cancer responding to immunotherapy. And so to just recount a little bit of history, I became acquainted with the field of comparative oncology now about 25 years ago. I learned a little bit about melanocytic tumors in dogs and from colleagues at the Animal Medical Center. And this was actually one of the dogs who was treated with the melanoma vaccine, Sinatra, the Siberian Husky. And really this was the beginning of a long and fruitful collaboration between human oncologists at the time at Memorial Sloan Kettering and the Animal Medical Center. The basis for the mechanism of the melanoma vaccine in dogs, and this is a shameless plug for my own dog, who is a patient at the Animal Medical Center. Thank you to everybody there for all of the hard work that you do. Is that as Dr. Lordahl shared, the melanoma vaccine encodes human tyrosinase, which is about 85% identical to dog tyrosinase. But that 15% difference is enough to convince the dog's immune system that this is different than self and to make a reaction to it. This is actually a photo of patient number 1 being treated in the phase 1 clinical trial of the melanoma vaccine at the Animal Medical Center. The 8th floor looks a lot nicer now, I have to say. That's Dr. Phil Bergman, who was my colleague and a friend, holding patient number 1, and as well as some colleagues from Memorial Sloan Kettering and a company that makes the needle-free vaccine device that is used to deliver the vaccine. And this is actually one of the initial chest x-rays, displayed, of course, in the inaccurate biped orientation of the first responding patient who had 2 lung metastases that both regressed after the first series of vaccines. This went on to be summarized in a paper that was published in Clinical Cancer Research back in 2003, summarizing our initial experience with the vaccine at the Animal Medical Center. And as you know, this went on to become a USDA-approved agent. In fact, really the first approved therapeutic cancer vaccine for any species. So very proud of that achievement. So what else have we learned about the immune system? Well, over the past 30 years or so, we've learned that there are a variety of different pathways that maintain what has been called immune homeostasis, that keep the immune system under control until it's really needed, and then return the immune system to a resting state after it has countered its target. And what this does is allows the immune system to jump into action when needed, but then to return to this resting state to avoid exhaustion of the immune response, and also to make sure that any autoimmunity is limited. And so I know it's late in the day for all this molecular pathway stuff, but I just want to point out a few things here, that the immune system needs to get activated based upon multiple signals. There needs to be recognition of the antigen, here this red ball, the target of the immune system, by the T cell receptor. That's signal 1. That is insufficient by itself to get the immune system activated. It needs to be accompanied by a co-stimulatory signal, also called signal 2, which in this case is a recognition of a co-stimulatory molecule, CD80 or CD86, by the activation marker CD28 on the T cell. When the T cell gets activated, it actually produces hormones called cytokines like interleukin-2. And this molecule called CTLA-4, which normally sits inside the T cell, after the T cell gets activated, it's moved into this immune synapse, where it serves as one of the primary ways of maintaining immune homeostasis by beginning to control the immune system. And it outcompetes CD28 for binding to these co-stimulatory molecules, and it shuts off the immune system. The seemingly unpronounceable antibody that Dr. Ferrari mentioned, ipilimumab, is an antibody that blocks CTLA-4, shown here. And this hypothesis that blocking CTLA-4 would be a way to enable the immune system to control cancer was actually theorized by my colleague, Dr. Jim Allison, for which he was awarded the Nobel Prize in Physiology and Medicine in 2018. And ipilimumab is, in fact, an antibody that blocks CTLA-4 and, in fact, can lead to melanoma regression in people. This is actually a patient. Interestingly, a patient referred to me by Dr. Pavlik, last night's speaker, when she was working at New York University and I was working at MSK, now back almost 20 years ago. This patient had metastatic melanoma that really covered the anterior surface of the left thigh. And you could see all this palpable nodularity, some of it hyperpigmented in nature. And after 2 doses of ipilimumab, all of that palpable disease regressed. Interestingly, there were still areas in the post-treatment photograph here that appeared hyperpigmented. And so we were interested to see whether that resembled residual melanoma or not. And so we performed a biopsy, and this was interpreted by Klaus Busam, who's a dermatopathologist at MSK. And he called this a tumorous nodule with melanin pigment. And this is actually what Dr. Lordahl referred to earlier as really a melanophage, a macrophage that is stuffed with the melanocytic debris of dead melanoma cells. And under a bit higher power, you can see macrophages and lymphocytes, but no tumor cells. And then with immunohistochemistry, we can see that this, what was previously an actively growing tumor, was now quite full of CD8 positive T cells, as well as CD4 positive T cells, as well as macrophages in the background. So this was really nice visual confirmation that the immune system could actually jump into action and control, in this case, quite widely metastatic melanoma and replace actively growing tumor with a robust immune infiltrate. The first really 5 years of ipilimumab use in melanoma are summarized by this curve, which was the work of Dr. Schadendorf, and was published now 9 years ago, showing that although most people still died of metastatic melanoma, there is this very characteristic tail on the curve at about 20% that becomes durable after about 3 years. And so even though having 20% long-term survival is nothing to get excited about, in the context of the fact that before the development of ipilimumab, this tail was at about the 2% level after 2 years, was sort of a step in the right direction. That this really was this was the first drug in human melanoma to demonstrate a change in overall survival in a phase 3 randomized trial. And so it really was a source of hope for patients, but it opened the door to investigating other immune checkpoint blocking strategies as a way to control this, what was previously a nearly uniformly lethal diagnosis. And Dr. Lordahl mentioned the PD-1 pathway. So this is PD-1 stands for Programmed Death 1, something that our patients really like hearing, that they're getting a drug called Programmed Death 1. But this was really because the drug was discovered based upon its binding to this molecule PD-1, which was first described by Professor Tasuku Hanjo from Kyoto University. Dr. Hanjo was a scholar of apoptosis, or programmed cell death, and he named this molecule PD-1. It quickly became known that PD-1 was critical in mediating the exhaustion and death of T cells, and that tumors, actually on the left side here, expressed the ligands for PD-1, PD-L1 and PD-L2, showing, in fact, that when T cells wandered into the tumor microenvironment and had an upregulation of PD-1 on their surface because they were beginning to become activated, tumor cells could actually kill those T cells by activation and expression of this PD-L1 gene, which happened in the context of inflammation in the tumor microenvironment. So this was a clear example, actually, of how a T cell coming into a tumor to kill the tumor cell could actually be killed by the actions of the tumor cell. And a clear example of the ways in which tumors can evade the immune system. And so this was one of many reasons why agents that block this PD-1 pathway were developed for cancer therapy. One of the first of these agents is called pembrolizumab. It was investigated in a phase 1 clinical trial called Keynote-1. I had the privilege of being one of the principal investigators of this study at the MSK site. And what you can see here in this waterfall plot is that each patient, this is a human patient with metastatic melanoma, is represented by one of the vertical bars. If the bar goes down, it means that the tumor burden shrinks. If the bar goes up, it means that the tumors were growing. The difference in color, the yellow bars are patients who had previously been treated with ipilimumab, the CTLA-4 blocking antibody, and did not have a good response. The blue are patients who were naive to ipilimumab. And so what you can see is, first of all, there are a lot of patients who had tumors that either stayed stable or regressed when they were treated with pembrolizumab, and that there are about an equal number of yellow and blue bars, implying that even though both ipilimumab and, in this case, pembrolizumab use the T cell as the mechanism of controlling tumor growth, the way in which each drug activates T cells are non-redundant. So that even if the patient's tumors are refractory to, in this case, CTLA-4 blockade, they still could respond to PD-1 blockade. And that was a very important observation, and it really led to the opportunity to investigate both of these strategies, blocking CTLA-4 and blocking PD-1 in a combination approach as a way to increase the likelihood that we could control melanoma. And so I'll present to you some data that was actually just published back in September and presented at the ESMO meeting in 2024. This is the 10-year survival data from a trial called Checkmate 67, which was a phase 3 randomized trial of nivolumab, which is a PD-1 blocking antibody, plus ipilimumab, the CTLA-4 blocking antibody in advanced melanoma. And so this was the trial design. It was a 3-arm study that was conducted globally at about 130 sites in 945 patients. This was the first immunotherapy that patients received for the treatment of metastatic melanoma, and they were randomly assigned to either ipilimumab alone, nivolumab alone, or the combination for treatment of metastatic melanoma. And these are the 10-year data. And so what you can see now is that in the top line, which is the kind of brick red color, these are patients who were initially assigned to receive the combination therapy. And their overall survival is no longer in like that 20% range. Their 10-year survival is now up around 43%. And in fact, you can really see that there's quite a change in the shape of this survival curve at about 3 years. And intriguingly, when you follow people for this long a period of time, there are competing causes of death. There can be heart disease, other cancers, strokes, of course, COVID, et cetera. And so we looked at melanoma-specific survival as well, which sort of tells us the difference between death from melanoma and death from other causes. And you can see that, very few people who were alive at 3 years went on to die of melanoma during the ensuing 7 years, out to 10 years. So we only see a drop off of about 9% of people dying of melanoma between 3 years and 10 years. And so the melanoma-specific survival in patients treated with the combination is actually about 50%. We still have room, to improve for sure. But this is quite a different outcome compared with when I started practicing in the year 2000, when median survivals for melanoma were measured in about the 6 to 7 month time frame. And now there are toxicities of these drugs. Many of these toxicities are inflammatory in nature. They represent the symptoms of kind of acute autoimmune disease, rash, colitis, liver inflammation. And in people treated with the combination, you can see that nearly 60% of people will have a high-grade adverse event, as opposed to less than half of that when you use the individual component parts. So sometimes we use single agents when we think that people don't have the medical reserve for some of this toxicity. But we've been able to derive good algorithmic ways of treating these toxicities and have very few treatment-related deaths. The mainstay of treatment for these toxicities is actually judicious use of corticosteroids like prednisone or TNF blocking drugs. And intriguingly, the use of either steroids or other means of immune suppression at late time points when the toxicities occur, usually 8 weeks or more later, does not seem to interfere with the anti-tumor activity. So this is just a summary of some of the toxicities that we see. Just about every organ can be affected. These are just some photos of some of the rashes that can occur. Vitiligo, obviously in deeply complected individuals, vitiligo can occur, and although not medically life-threatening, certainly it is very significant source of social stigma. Diarrhea and colitis is a beautiful pre-dinner photo of the inside of someone's colon that's quite inflamed. Importantly, there are some quite rare but interesting toxicities. We can see inflammation of some of the endocrine organs, the thyroid, and rarely the pituitary gland, which can present just with very nonspecific symptoms like headache and fatigue. When it can become more prominent, we can see visual field defects. But what you can see here on this MRI scan is quite a significant enlargement of the pituitary gland. And while this will regress, very often many of these endocrine toxicities will lead to the need for lifelong hormone replacement. Pneumonitis can occur. This is a CT scan showing a lung inflammation. It can often be mistaken for pneumonia, and at the beginning of this experience, people were treated with antibiotics and for a few weeks and not getting better. Some of those patients actually, unfortunately, died. And so when people present with interstitial pneumonitis like this, or that can be mistaken for pneumonia, if they don't respond to antibiotics after a few days, initiation of corticosteroids is actually quite important. I want to give you, in the last few moments here, some examples of how practice patterns have changed. We used to do surgery up front for advanced melanoma, surgery for the primary tumor, as well as involve lymph nodes. And then we would give immunotherapy in the adjuvant setting to try and decrease the likelihood of recurrence. In the past few years, we've had significant data accumulate that neoadjuvant therapy, or treatment with immunotherapy before surgery, can be quite a bit more effective than use of immunotherapy after surgery, with the hypothesis being that when we remove the tumor or the tumor-draining lymph nodes, we're actually removing the bulk of the tumor-infiltrating T cells, which are present in the tumor or the draining lymph node sites, and sending them to the pathology lab, when perhaps it's better to leave those sites in place for a few weeks, give a few doses of immunotherapy, and then do surgery. And this is exactly the experiment that was done by the Southwest Oncology Group, led by Dr. Sapna Patel, where they actually did a very clean clinical trial of surgery followed by 18 cycles of anti-PD-1 therapy, or 3 cycles of anti-PD-1, then surgery, then the remaining 15 cycles of anti-PD-1 therapy. And the event-free survival showed a clear and statistically significant difference favoring neoadjuvant therapy. And so this has now become more the rule rather than the exception. And many patients with palpable lymphadenopathy, who would ordinarily undergo surgery of the primary tumor as well as the lymph node basin, are given immunotherapy first. And consideration is now being given to moving this therapy into the stage 2 for humans, HACC stage 2 disease, for a thick primary tumor as well. But this is still a concept in evolution. Just want to introduce another immunotherapy, which was more recently approved, a drug that represents a combination of nivolumab that blocks PD-1 with relatlimab, which is another immune checkpoint blocking antibody that blocks the LAG-3 pathway. This was evaluated in a clinical trial comparing anti-PD-1 nivolumab alone along with the combination. And you can see a modest improvement in progression-free survival for the combination over nivolumab alone. And in addition, as Dr. Lordahl said, in human melanoma, the BRAF kinase gene is mutated in about 50% of human cutaneous melanoma specimens. And we have small molecule tyrosine kinase inhibitors that block BRAF and its neighboring molecule MEK. And so we were faced with the question of whether it's better to give targeted tyrosine kinase inhibition or immunotherapy as the first treatment for patients with metastatic BRAF mutant melanoma. And so the Eastern Cooperative Oncology Group performed this DREAMseq trial, which compared immunotherapy first, followed by tyrosine kinase inhibitors if there was progression, with the combination of tyrosine kinase inhibitors first and then immunotherapy at the time of progression. This is a trial led by Dr. Michael Atkins from Georgetown and showed a clear advantage of immunotherapy first in the black line compared with targeted tyrosine kinase inhibition first in the red line. So we now have some general lessons that we've learned, that it's better to give immunotherapy first if you have a choice between immunotherapy and tyrosine kinase inhibition. And for patients with at least regionally advanced disease, it's advantageous to give immunotherapy before surgery as a way to enhance response. And I just want to finish up with sort of what we've arrived at as a central dogma for checkpoint blockade immunotherapy. That, as I said at the beginning, the mutational landscape fuels a baseline immune response. More mutations equals more likelihood of the immune system being activated, finding something interesting, different from self. Primary immune evasion and adaptive resistance restrain this immune response, and that's why the patient shows the cancer. And checkpoint blockade may disinhibit this baseline response to achieve regression and antigen spreading, leading to durable disease control in some patients. There's a long list of reasons why patients may not respond to checkpoint blockade, and these form the basis for some new combination treatments that are in evaluation. But we also know that supplementing the immune repertoire with engineered T cells or ex vivo expanded tumor-infiltrating lymphocytes to really change the repertoire, if there's nothing to be disinhibited, may be needed in some patients with non-immunogenic tumors. And most recently, about 6 months ago, a new drug was approved for human melanoma called lifoleucel, which is ex vivo expanded autologous tumor-infiltrating lymphocytes. So basically, the patient has a metastasis resected. The metastasis is sent to a company where in their laboratories, the lymphocytes are separated from the tumor cells. The lymphocytes are expanded over about a 2 to 3 week period of time, and then reinfused into the patient after the patient is given cytoreductive chemotherapy as well as interleukin-2. And what you can see is that about 30% of patients who have checkpoint blockade refractory melanoma will actually show an objective response when given tumor-infiltrating lymphocytes. So the era of cell therapy for melanoma has arrived in terms of a standard option, and we're looking forward to exploring others. I want to finish up by thanking all of my colleagues at Weill Cornell Medicine, especially my long-term collaborator, colleague, Dr. Taha Mergoob, who co-leads the laboratory and is the deputy director of the Cancer Center here. We are eager to collaborate with our colleagues at the Animal Medical Center so that we can find better ways to control melanoma and other cancers using immunotherapy or combinations of immunotherapy with other cancer treatments. Thank you so much again for the invitation to present today.
Well, thank you both very much for your very engaging and interesting talks. Really appreciate you taking the time out of your evenings to talk through that information with us. We do have a couple questions in the chat that are coming through. A little bit about kind of concurrent therapies. And Dr. Wolchok, Dr. Liebman mentioned that Dr. Beal the other night mentioned using corticosteroids in conjunction with radiation therapy, and that it can, looks like, diminish the response of metastatic melanoma to the brain when used together. And you had mentioned using steroids in order to reduce toxicity side effects of the therapies we're talking about today. So wondering if you can comment on kind of that dichotomy of action of steroids, when to prioritize it, when to not. How do we make that clinical decision?
Yeah, so I think what Dr. Beal's referring to is that very often corticosteroids are used up front, in the treatment of brain metastases because of the edema that can be present at baseline. And so we know that the timing of when the steroids are introduced is critically important. So if steroids are on board when we initiate immunotherapy, then we know that the likelihood of response is close to zero. But if we introduce corticosteroids after the immune system has been activated in the context of treatment of toxicity, because the toxicity is really mechanistically the same as the anti-tumor activity, we know that it is quite safe to give corticosteroids at that delayed time point.
Great, that's very helpful to know. And I think one challenge that we've had on the veterinary side of implementing some of these immunotherapies is kind of the toxicity associated with it, especially because our goal with our treatment for our veterinary patients is always focused so much on quality of life, not always on duration of life, right? Because we can't explain to dogs, this is a temporary crummy feeling, but there's a goal on the end of this, right? So we always want to make sure that our pets are feeling well. Do you have any strategies, or has anything come up in your clinical practice to try to preempt patients who might have toxicity from immunotherapies, or select which patients will, and how to navigate that?
I wish that we did have a way to identify people who are at risk, especially of severe toxicities. We don't really, we can't really do that with any degree of precision. Even people with pre-existing autoimmune disease, there is no guarantee that their disease will flare. We know that they are more likely, but it's not a guarantee. So we of course have, I think, much more in-depth discussions with people who have prior histories of autoimmune disease before using these medicines.
That makes sense. So kind of tailoring for the patient if there's any comorbidities specifically that are already affecting the immune system, or immunomodulatory medications on board.
Yes. Yes.
Thank you. Interesting question in the chat now about is an excisional biopsy of a melanocytic mass, so removing the gross disease, not recommended if immunotherapy prior to surgery is more effective to kind of kickstart the system and have that stimulus present for the immune system. I suppose the question, as I'm interpreting it, would you ever deprioritize surgery, start with immunotherapy, and then follow with surgery later on?
Are you asking me or Dr. Lordahl?
I'm asking you. Dr. Lordahl can comment too if she has
thoughts. I think we would always want to have histologic confirmation of the diagnosis, right? So at least, a biopsy to prove that it is malignant melanoma is important. Depending upon the admittedly, rough estimate of risk of recurrence, that's really how we decide whether or not to give immunotherapy up front.
That makes sense. Great, great. Dr. Lordahl, do you have any thoughts on our veterinary side?
We definitely will be recommending biopsies. As I mentioned earlier, it's important to know what you're treating. So we would start with that and then incorporate the other therapies as fit.
Great, thanks very much. And I think we're coming up at 8 o'clock here, so I'll say thank you very much to both of our speakers for taking the time and talking through this very interesting and complex disease process with us. I'm hopeful for many more collaborations in the future to help advance both fields. And I do know that Kim has sent through the link for CE in the chat. So please be sure to click the link in the chat box or scan this QR code that's up on the screen right now to submit your CE credit request, and certificates of attendance will go out tomorrow. So thank you very much, everyone, and have a great rest of your evening.
Thank you.
Thank you.